Welcome for this plenary session in the afternoon. We are going all the way down under. It's 12 hours later. No, earlier there. Or not? What is it? Earlier, yeah? Yeah, 12 hours earlier. So it was hard to find a good time to talk to our next keynote. But we did, because he arrived earlier in Europe. And I wonder if he feels like Alice in Wonderland in Europe. Because in Australia, we are talking about Australia, they have already an Australian digital health agency. And they even have a chief digital officer, Peter O'Halloran. Peter, join us on stage. Big hand, ladies and gentlemen. He really boosted the digital transformation in healthcare in Australia. And so we are, of course, very curious. What is the secret of your country that you did?
We did lots of things, but most of all, we spoke to healthcare consumers and clinicians.
Okay, tell us all about it.
Absolutely. So, thank you so much. Lovely to be here. Just in case those of you haven't really thought about the differences between Australia and the Netherlands, I'll put a few statistics up there for you. What I would say is I've been in Europe for the last week and a bit now, which has been lovely. And I've been here for a couple of reasons, but the most important one was last week I spent a lot of time with a summit for the Global Digital Health Partnership, which is a group of countries, governments, where we represent about 40% of the world's population. And the summit was in The Hague and it was hosted by your colleagues from the ministry, who provided outstanding hosts and really did amazing things. But what it really reminded me was, and you can look at the slide there are so many things that are different about the Netherlands and Australia. If I look at any other nation, we can all bring up things that are different about what happens. Fundamentally, however, what last week reminded me is there are a small number of things where we're different, and land mass could be a slight one perhaps. Apart from that, there's many similarities. Weather, well, depends, but the weather's beautiful this week. There are far more things where we are the same. And talking to colleagues from across those countries last week, we talked about everything from AI, because you can't have a healthcare and digital conference without talking about artificial intelligence. We talked about things such as benefits realisation. We talked about interoperability and standards and all of those things you'd expect us to talk about. And the thing that really became apparent to me, and it's something I've always known, but it really reminded me, was 80 to 90% of those issues and challenges that I was facing at home are exactly the same challenges being faced by all other governments. And once again, it really does bring home to me that what we're talking about in healthcare is a global challenge. Yes, I've got a problem in the city I live in Australia, or in Australia as a whole, or my part of the world, and you have the same here in the Netherlands. But fundamentally, most of those challenges we have are the same. And we can't have a local solution to them anymore. It just doesn't work. And so in Australia, we've really been going down that path of re-engaging in the international standards space, and I'll touch on some of the details in a moment, to talk about how do we work with all those other countries, with those communities, with those standards organisations to actually achieve better health outcomes for all Australians. And I'm a bureaucrat, I work for the Australian government, and so we'll talk about papers in a moment, but fundamentally, we all work in healthcare. And working in healthcare, we have one goal, which is better health outcomes for that consumer, for that patient, for that person in front of you, whether it's someone you've never met before, it's your family, your loved ones. That's why we're here. So, talk a little bit about Australia. We have a checkered history, shall we say, in digital health. We've had a whole lot of innovations. We've done a lot of great things. We've also been absent for a few years in some times or other about digital health and innovation. We have what we call our My Health Record system. It's a teenager now. It's formed in 2012. We built this. It's, in essence, a shared health summary, which is accessible and controlled by the citizen. So over 90% of all Australians have a My Health Record. The citizen can control, they as a consumer or someone else they nominate on their behalf can control who can see what in their record. And if a clinician accesses their record, they can see who accessed it from which healthcare provider. In fact, we've had a couple of data breaches in Australia in recent years, unfortunately, the nature of the work we all do, that was actually discovered through the My Health Record system because a consumer, and I do the same, had notifications turned on. Every time someone accesses my record, I get a message on my phone that tells me, and I can go and look and see who accessed it and why. And normally it's very simple and boring. I've been to see my doctor or whatever. But a couple of data breaches we've had in Australia have actually been exposed by consumers seeing their record and seeing that somebody accessed their system, the system about them when they shouldn't have been there. So we've had this system for nearly 13 years now, and it's getting a bit old and aged, is probably the nice way of putting it. For anyone who cares deeply, it's all around a document-based architecture. HL7, V2, CDAs, if you really want to get into the technical details, but it's based around clinicians have an encounter with a consumer, they upload a document, and there it sits. 10, 15 years ago, that was pretty good. Today, it really isn't meeting our needs at all. So we had an election just over 3 years ago now, so we've got another one due soon, and our health minister was elected. And here's the words, and I'll read out part of them that I think that are the ones that are both equally exciting and terrifying in the same breath. I believe digital health represents the single greatest opportunity to transform healthcare in Australia. Just think about that for a moment. We have a minister who says digital health is the number one thing that will transform healthcare in Australia. That's incredibly exhilarating. It's also one heck of a big burden to put on any one agency to actually try and deliver against that. So what can I say? We get bored. As I said, I work for the government, so we have a blueprint and a roadmap and a strategy to go for everyone. Australia is grouped into states and territories, similar to regions or provinces, each of which has their own healthcare department, each of which has their own digital health strategy. Our equivalent of your ministry also has their strategy, or blueprint they call it. So of course, we then had the joy of trying to bring one single strategy together that harmonised the other 9. So we have the National Digital Health Strategy. It talks about what we're doing, the themes, the areas, and we're going through. We also have a National Healthcare Interoperability Plan, connecting Australian healthcare. And that really is where we get more tactical. What are we actually going to do to deliver better connected care for all Australians? And if you really want to get into the weeds, we also have a National Healthcare Identifiers Roadmap. And that's where you can sit there and read the line-by-line detail of where we need to change our legislation, what we need to do. But all this we're doing is completely transparent. So if I talk about our healthcare interoperability plan for a moment, there's the plans there, and there are 44 actions that are identified. And this was all developed over 2 years in conjunction with clinicians, consumers, bureaucrats, software vendors. Everyone across the country who wanted to be involved could contribute to it. And what came out of it was 44 actions. And we launched the plan. I launched the plan in July 2023, so it's just 18 months old. In 18 months, we've achieved a whole lot. 44 actions. We've completed 1/3 of them, or 32%, but let me call it a third. And we've progressed a lot of the other ones. Not only that, we are being completely transparent and publishing on our website every quarter a summary of where our progress is up to, where we're behind, where we're ahead, how it's tracking. And we've formed a Council for Connected Care, which is where we bring academics together with consumers, clinicians, the Royal Colleges that are our clinical groupings in Australia, as well as software vendors to actually work through and hold me accountable for ensuring that we're delivering all of this. And that really is a group that I love and hate at the same time. It's really exciting to go into the group with them. It's absolutely terrifying when they'll then sit there and argue with my staff and I about whether we really have completed that action. Is that enough work? Could I have done better? But that's a really good process we go through that actually holds us accountable and ensures that everyone across the country, across all parts of that Australian healthcare system, are part of the solution. And so the plan goes for 5 years. My intention is 3.5 to 4 years after its launch is to be finished. We can't wait 5 years for all these things to happen. We need to get there faster. So I'm going to talk for a couple of minutes about some of the things we're delivering under that plan. And I've put some QR codes there so you can actually have a look and see what they are. Alternatively, I could say it's a great cybersecurity test and see if it sends you some horrible website. So you can choose to scan it or not, your call. The first is the Digital Health Standards Catalogue. So we've been here today and listening to some of the amazing sessions I've been to. Heard an awful lot about fire, and that's really good. And I heard lots of discussions around HL7 and SNOMED, and I'm not going to argue whether SNOMED's a standard or an ontology and terminology, but All those type of discussions, all the normal things we would all talk about. Except if I am someone who's just come into healthcare, I'm working in a hospital or I'm working in a primary care practice and I don't have the time to think about it, how do I know what all those standards are? Yes, I can Google and find the top 2 or 3. If I can actually understand how to implement them, even better. But what we're doing in the catalogue is bringing all those standards together. And there's now over 1,000 there. And there's over nearly 500 more that we'll be adding in the next 2 months. And this goes to everything from fire and HL7 and links off to implementation guides, right the way through to really strange and esoteric things of how do I make my mobile phone work safely in a hospital so that it works in a lift going up and down a big tower block but doesn't interfere with an MRI machine. So they're the type of things that are on the catalogue. And part of what we're doing in the interoperability plan is really simple, tangible things that when you look at it, you go, that's common sense, we should have done it 10 years ago. Yes, we probably should have, but we're doing it now to make it easier for people trying to implement. And that's also why we have procurement guidelines. And no, I'm not teaching people how to buy and sell things. That is, no matter which government you work for, a horrible process. But instead what we're doing is, if you work in healthcare and you're going out to buy a system that might look at medication management or managing it at residential aged care facility, we're actually putting information up there that lets you go and say, what requirements for standards should I put into my requirements in the official notice or your approach to market or request for tender, whatever terminology you use, so that when the vendors are responding, I actually know that these are things I have to measure them against in terms of compliance with those standards. It's very unexciting, it's very boring, but it's a really popular tool that we've now released and we're continuing to evolve it for everybody. And so that's yet another simple thing that we're doing but makes such a difference. We also have Spark, a fire accelerator, in one of the sessions I was in earlier today. Great work stream talking about sort of fire and open air and where it's going. And there was a reference to Australia and a reference to Spark. So we have Spark, it's a fire accelerator. I have to promise them, I did actually, where they have promotional material, I've got Spark socks on. They do t-shirts and socks and it sounds silly, but we get a lot of excitement there. Spark is an accelerator that brings together healthcare consumers, clinicians, software vendors and government in one room. And we're doing it all across the country. We have working groups meeting every week in different areas and different streams. We come together quarterly, face-to-face in different cities to work through what we're doing, and it's very much it's a community-based process. We are developing a whole range of items around fire on a community basis. And here's some of the things we're doing. We're doing implementation guides. We're looking at things such as developing an Australian Core Data for Interoperability, or AUCDI set, and that's going very well. We're up to the 2nd version of that that's being balloted at the moment. We're also doing implementation guides for fire. This all sounds very exciting, maybe, maybe not, except when I then overlay it and say to you, within the next 3 years, we will have upgraded our My Health Record system to have a fire-based repository. In the next 2 months or less, I expect to be able to make an announcement of which vendor, we're currently in the middle of a procurement, who'll be operating that new fire-based or providing it for us. Every major software vendor who is selling into Australia is involved in that Spark community. Less than 5 years from now, I expect that HL7 V2 messages plus faxes, and yes, we still have an awful lot of those, and we have the same problems everyone else does, thankfully it's not in our regulations, will be moved off those for things between health services. Inside a hospital, I imagine HL7 messages will continue probably until I'm in the grave. Let's be honest, there's lots of systems, lots of messages going. But between healthcare services, we will have moved to fire, and that will just be routine in less than 5 years in Australia. Fire is exciting, it's good, but ultimately it's just, in essence, a transport protocol. Slightly dumbed down, but in essence that's how I see it. It's how you move the data from point A to point B. Coming from Australia, where we had somewhat of a role to play in establishing fire in the first place, that's rather embarrassing to say. Nearly as embarrassing to say that over 10 years since its inception, up until the last 12 months, we'd done almost nothing with fire in Australia. That's now changing, and we expect to transform our healthcare system and the data exchanges using fire in less than 5 years. We're also focusing very heavily on SNOMED CT. And we're currently pushing heavily, we're a founding member of SNOMED International, or ITSTO as it was in the day. We're pushing very much to integrate that natively into every single clinical system we have. To try what we call Australian medicines terminology, which is in essence how we do medications and it's tied to SNOMED, into all of our prescribing practices. We've already started doing this with some systems and we're seeing clinical benefit. We're seeing a reduction in patient harm. We're seeing easier exchange and coding of data. So really this is an area we're focusing on massively in the next 2 to 3 years. I'm sure AI will solve all of those problems, and everyone tells me you don't need to code, you don't need ICD, you don't need SNOMED. I'm somewhat more cynical, and I think very much we heard from Bianca this morning, garbage in, garbage out. Much higher quality data going in will make a big difference. And part of what we're also developing is a digital twin in Australia for every single citizen. So as Australia goes down the path of modernising, as we go down the path of precision medicine, where the costs of precision medicine are so expensive, we can't afford to get it wrong, and we can afford one shot generally to get it right for a patient. Having a digital twin where a clinician can actually sit through and run through the scenarios and see what's actually happening is a big part. We're also giving consumers control of their own health information. On my smartphone, I can access my health records. I can look up a health provider, see any health provider in Australia in one app. I can search for them. I can book in a time with my general practitioner, my family physician. I can even, when I see them, I'll get a whole of health information about you need to go and get more exercise. I can probably imagine they're going to tell me that. I get told that every time. Further information in my app about that. I can also get any prescriptions for medications, see all that there in the app. In essence, what we're trying to do is make it easy for Australians to have all their information, your health in your hand. I work with lots of people who get very excited about the product, so I promised them I'd show you this. In essence, however, what we're trying to do is put all this data to give consumers that power so that they are in control of their own health and their condition, not being subject to what is imposed upon them by the system. We're also going through, as I said, my health records now become a teenager. Probably not as troublesome as my 2 teenage sons, but getting close. We are completely modernising it. Over the next 5 years, we are ripping and replacing every part of what we built 12, 13 years ago. We've done the first part, which is a new API gateway. Sounds very unexciting, and let's be honest, it is, except it gives us the core technical foundations that lets us exchange data much more readily. The next part is we're moving to a Fire-based repository, and that'll be in service, in production, with consumer data in it before the end of this calendar year. Not content with that, we're also building a National Health Information Exchange. And the National Health Information Exchange will operate in parallel to our My Health Record system. We look at our My Health Record system very much being a shared health summary. It's the critical information that clinicians need to treat the patient in front of them at that point in time. So medications, allergies, test results for pathology, radiology. The Health Information Exchange will be access to the full record. This is the type of thing we're doing in Australia at the moment. We are doing it all using global standards. We are doing it in collaboration with our community, with our consumers, with our software vendors. And what I would say is, please keep working with us on the journey. Your ministry has been incredibly generous in working with us. But this is just a taste of what we're doing. And what I would say is, after sitting through some of the amazing sessions today, almost every single problem I have in Australia seems identical to what you're doing with here. So there's some further information. I post on LinkedIn, there's a QR code for that lets you see all the crazy things we're doing. And that's enough. Thank you, Maria.
Thank you. Thank you, Peter. Peter, I'm wondering, you showed us the codes and the guide which you published. Can you see that it's used more often nowadays?
We can. And look, every week my team watches all the statistics on the website.
Yeah.
We've seen the growth go up over 1,000% in the last 3 months.
Okay.
And that's despite it being the middle of the Australian summer and all of our holidays.
Okay.
So it's being used. And not only that, people are writing into us every day saying, why isn't this here? When are you going to get to this part? So it seems to be working. Yeah.
And you said, well, we have standardization, harmonization. Was there any resistance, and from whom?
There was. We had a lot of local standards in Australia, and that was really good for our own local software industry because it kept all the other players out until they worked out they couldn't sell their software overseas.
So the vendors were the
vendors were objecting now. The vendors are the biggest advocates saying, why can't I move faster? So
okay.
You can't
they
keep
see
them happy.
Opportunities
It
also.
is, but it's one of those things, I think, change is scary for all of us. As they're seeing the benefits, it's really transforming how they look at it.
Yeah. And how do the insurance company, the health insurance company react?
The model we have is largely our Australian government pays for most healthcare costs in Australia, so the insurance companies have a much smaller part to play. In Australia, the healthcare insurers can't legally be involved in deciding what care a patient can receive.
Oh, that sounds very nice, isn't it? I don't know if I offend somebody, but...
It really does change the dynamic, though. It means we're not driven by price so much.
Okay.
Yes, we need to deliver more efficiencies. Yes, capacity is limited, but we're not having insurers decide that I can get a certain level of care or not, which is a good thing, I think.
Okay. Shall we go to the audience?
Absolutely.
Can I have the light? Because it's so dark for us. Yeah, that's nice.
Now you all have to wake up.
You have to wake up, yeah. Questions? I see that the first one. Sorry to interrupt. Wie was het? Ja? Oh, sorry. Ga even staan, want dat is handiger.
You have to work the question here.
Hi, my name is Mats Koenman from the Radboud UMC. I was thinking, how did the healthcare providers react to such a top-down directive? Because I can imagine in the Netherlands, if the ministry would have such a roadmap, it would cause also some of the barriers or resistance.
So we established our My Health record system in 2012. It was very much controlled by consumers. Clinicians could determine how much information they shared. Our biggest failure was doing that because clinicians did not contribute enough information because they didn't see a value in it for them. Since then, COVID hit, where suddenly all of our healthcare consumers just expected that everything in healthcare would be shared, that data would just flow seamlessly. And thankfully, none of them actually understood how bad it is behind the scenes, that we all know healthcare is, and it's not really a system, it's just a series of warring groups put together. And so I think that consumer demand is what's changed fundamentally the view of the clinicians and the consumers.
So the corona crisis helped?
Well, look, never waste a good crisis, and if you haven't got one, invent one. Sorry, I shouldn't. Please don't record that. Yeah, that Peter said create a crisis. But part of it's a top-down approach. A lot of it's also driven, though, by what the clinicians are telling us they want. And so all of those strategies, those roadmaps, most of the writing for that was done by healthcare consumers and clinicians, not by bureaucrats like me. Secondly, we've put a lot of trust in our fire accelerator Sparked. As a bureaucrat, it's truly terrifying to say, I can't control what goes into the outcomes of that group other than a very broad set. They run their own balloting processes, they make decisions, and the 90% of those members are consumers, clinicians, or software vendors.
So it wasn't a top-down approach, it was...
It's both.
It's
both, and so it's kind of, we're doing top-down where it makes sense, but a lot of it is also community-driven. The number one complaint, though, is why haven't I finished?
And is that also the role of your council, because all the parties are in the council?
It is, and we use that council, that's also, it monitors me and keeps me honest for what we're doing. And that is a big part, and the council is open, all of their papers are shared online, their members can post whatever they like. Sometimes it's good, sometimes it's not. But that really helps with actually ensuring that clinicians feel that it's actually something they're in control of, not me.
Okay, other questions?
Excellent, I know I'm between you and drinks or a couple of other speakers.
Are you all tired already? Do I miss somebody? Actually, talk about patients. I will come to you. Talking about the patients, is it organized patients who reacted, or is it also individual patients who reacted in the period you were developing?
Both. So we have a series of patient-organised groups in Australia, the Consumer Health Forum. There's all sorts of other groups. We interact with them. We actually fund them to enable their members to come and be involved in the work we're doing. But we also put a call out, and so we will literally go to survey firms that do sort of brand management for big companies and actually get them to identify ordinary Australians. I'll then pay them to come and spend a day with us, so we pay them all for their time, and they're completely randomly selected to work with us. So we do, for example, our My Health app, we do co-design. Yeah. With consumers and clinicians in the room at the same time. That was somewhat confronting for the clinicians at first. Now, if I try to do it without consumers in the room, I get in trouble. Yeah. And all those consumers are randomly selected, plus anyone who actually writes a comment on the Apple App Store or the Google Play Store, positive or negative about our app. the team actually reach out and say, look, we run focus groups. Would you like to be involved? Would you like to send us a survey? So we try and target the consumers at a variety of different levels.
So they now react different than in
Well,
former
exactly.
days. Yeah.
And if they've gone to the effort of actually writing a review, the least I can do is actually invite them in to try and work with us to make it even better.
Yeah. Okay. Please stand up. You are.
Thank you. Ronald Graffey from Kaya House. I was wondering, I saw the population density is 3 point something people a square meter. So, certainly there's distances to bridge. So maybe you can share some lights on the use of telemedicine. And also I'm thinking about in the area of, when you mentioned the digital twin, do you use that for preventive care assessments or something?
The digital twins in the vast area of Australia.
I'd love to say we're doing all those amazing things for preventative medicine. We're not that good yet. We still struggle, like everyone else, to deal with basic things like workforce challenges, backlogs of surgery, emergency departments where the demand has grown by nearly 50% in the last 5 years. Preventative health is where we should be. We're not there yet. We pay lip service. We do a tiny bit, but realistically, we're not doing anything of substance yet. That, I hope, will change dramatically in the next 2 or 3 years, and that's where I see the power of digital health, where we can suddenly do that sort of preventative or population health level at scale in a way we could never do before. Telemedicine in Australia is used somewhat, not nearly as much as it should be, but it's primarily used by healthcare services to connect people in remote areas to another clinician elsewhere. So we use it an awful lot we often have small hospitals that might have 2 or 3 nurses or an aid post, and there's no doctor within 2,500 kilometres. That's where we'll use the telemedicine a lot. So there's a trained clinical person there who's then the remote clinician can use sort of high-definition video, see all the vitals and the monitoring systems, but also have a clinician they can trust to actually give them additional information. Can we do more? Absolutely, but it's probably an area we're still working on.
Top. Thank you so much for all your information and also very inspiring. Thank you,
you.
Peter Halloran, ladies and gentlemen.
Thanks, everyone.